Our next student host coming on is Jamelia Harris. She's here with us now. And Mr. Jesse Violet, I invite you to stay if you have the time to participate in this conversation with COVID-19. So if you have time, we're welcome to stay, because I'm sure there's going to be some kind of overlapping of conversation. So thank you so kindly. Now we let us take. We were supposed to schedule for a 10-minute break, but we watched through this. But let's take a about a 3-minute break. Let's take a pause, because staring at a computer screen is right now for me is getting painful. So I know it might be painful for you all as well. So let us take a 3-minute break, and it will come right back. I'm going to pause the recording so if it doesn't get anything offset. Welcome back, everyone, to the second session for today. This session will have two persons. One is Dr. Dominic Mack, and the other is Respondent Dr. Rueben. And this is on the ethics of COVID-19. So I will introduce to you now our student host for today, Ms. Jamelia Harris. Ms. Jamelia Harris is a freshman psychology major from Columbus, Mississippi. She was raised in Mississippi all her life by her father, Carlo. He is a middle child between two brothers and is dating her boyfriend of 3 years. Earlier this year, she graduated from New Hope High School in May with high honors. While in high school, she was involved in many activities, including band, where she played alto and bass clarinet, the National Beta Honor Society, and robotics. This is the first year in the Biotics Honors Program, and she's excited to be part of it. Her passion for mental health, which started in middle school, shaped her future vision. Currently, she's on the pre-med track and obtaining a bachelor's degree in psychology. After graduating from Tuskegee University, Jamelia plans to attend medical school to achieve a goal as a child psychiatrist. Her dream to work predominantly with Black children and families to destigmatize mental health in the Black community. She plans to use her time as wisely as possible to ensure her success in the future, while also appreciating the present. As of now, Jamelia is an e-board member of the Psychology and Sociology Club and Crimson Curves and Minority Association of Pre-Health Students. Her passion includes painting, writing, music, and reading. I present to you now Jamelia Harris, and she will read and she will introduce to us our speaker for today.
Dr. Mack is Professor of Family Medicine and Director of the National Center for Primary Care, the nation's first congressionally sanctioned center to develop programs that strengthen the primary care system for health equity and sustainability. Dr. Mack, a family physician, is a longtime proponent of electronic health records. Dr. Mack practiced for 11 years at Southside Community Health Center in Atlanta, where he served as Chief Medical Officer. He joined MSM in 2001 as an assistant professor in the Department of Family Medicine. While at MSM, he has served as medical director and interim residency director for the Department of Family Medicine. Dr. Mack serves on numerous committees, including MSM, ASO, HIT, GAHITEC, Executive Faculty, Community-Based Health System Initiative Planning, and NCPC Executive, just to name a few. Under Dr. Mack's leadership, the NCPC has several critical focus areas that include health disparities, access to care, and healthy lifestyle behaviors. He has been published in several peer-reviewed scientific articles and book chapters, and given hundreds of lectures nationally, including most recently MACRA at the Georgia HIMSS conference in September 2016. He is also presented at the National HIMSS Conference and will appear again at the 2017 HIMSS National Conference. While other presenting topics encompass meaningful use of EHR technology, innovations of healthcare technology, health transformation, and the impact on the patient-centered medical home. Some of Dr. Mack's publications include topics such as mitigating the health effects of disasters for medically underserved populations, electronic health records, telemedicine research, screening, and surveillance, paths to success, optimal and equitable health outcomes for all, and missed policy opportunities to advance health equity by recording demographic data and electronic health records. Mack received his Bachelor of Science degree from Payne College and his Doctor of Medicine degree from Meharry Medical College in Nashville. In 2003, he graduated from Kennesaw State University with a Master of Business Administration.
Thank you, Ms. Harris. Appreciate that. And also, we're proud of the great work that you're doing. So thank you, and you continue on, and we'll be here to support. We know you're going to do great things. I want to thank you, Dr. Hodge, for the day and for being our grand host. And also, Dr. Warren, thank you so much for inviting us. And Dr. Mallon, he did touch on a lot of things that also cross-cutting from the things I'll talk about, and I'm sure that Dr. Warren will talk about as we go forward today. So let me share my screen. You can see it?
Yes.
And can you see it move?
Yes.
Okay, great. So today, what I'd like to do is talk to, just a second. I'd like to talk about linking communities through strategic partnerships, and briefly talk about COVID-19. It's basically an overview of COVID-19. And Dr. Warren asked me to share some work we're doing on the National COVID-19 Resiliency Network, which I'll talk about. Here's the outline. I just want to cover these 4 things, give you a little background and framework about the work we do at Morehouse School of Medicine, specifically the National Center for Primary Care, but most importantly, the importance of frameworks when it comes to solving the problems that we have in our communities. Talk to you about community approach and evaluation, basically how we use big data, health equity research to solve some of these problems, specifically around COVID. The importance of technology and innovation when it comes to approaching communities and under-resourced conditions, and improving access, not just for the patient, but for those clinicians those health professionals who serve the communities in which we serve. And then I'll talk about our partnership, the work we're doing with Dr. Warren and the center and Tuskegee around helping communities to overcome barriers to get treatment, prevention, et cetera, when it comes to COVID-19. So the National Center for Primary Care, our mission is to strengthen the primary care system through education, research, training, to improve the health outcomes while advancing health equity, which meets with the overall mission of Morehouse School of Medicine. Current president, Dr. Valerie Montgomery Rice, but also past presidents, Dr. Maupin, who's a good friend of Dr. Warren, and then Dr. David Satcher, who was the first director of the National Center for Primary Care. We focused on education and training, but that's based in around policy, technology, substance use disorder prevention and treatment, but also doing the research, providing the evidence, but also proving that certain methodologies work when it comes to implementing solutions within communities. But one of the things I want to talk to you about with the framework, and put my time up here so I won't go too long. But one of the frameworks we use to approach communities is the PEDAL framework, where we have to prioritize the needs of the community, the work that we're all doing, but this is a published publication, and this is a framework that we kind of refer to with any new research, grant, publication, but especially those implementation initiatives like the National COVID-19 Resiliency Network, and I'll refer to that as NCERN as we go forward. But you have to actually understand the community, prioritize the needs of that community, and that takes engagement with the community. We talked about the old community-oriented primary care, where we used to say that if you go into a community and there's dilapidated cars, there's shootings, the street lights are not on in the inner city community, for example, you may need to address that. You will need to address that before you talk to that community about health. What's foremost on the mind of a mother and a child who may not have enough food to eat during that week? You can't go in there and just talk about health. You have to engage the community, see what their needs are, see what their understanding of the issue is, and what their view is. And Dr. Warren speaks to this so much when we talk about the bioethics. We have to target those needs, but also solutions around those needs of the community, as long with those best practices that we're implementing. Then we have to act on it, measure the success of what we're doing, and then that continuous learning process to come back, that loop of coming back. So we need frameworks that understand our community as we enter the doors of our community, no matter what the color, no matter what their disability may be, what their vulnerability may be. And I know we have all different type of terms, disproportionately impacted, but all those communities that we serve to try to improve the health and provide equitable solutions. So let's go ahead and talk about the community approach and evaluation and some of the work we did around COVID-19. What did COVID-19 bring to the surface? Some of the same things that other disasters and previous disasters and pandemics have done. It magnified the long-standing neglect of our communities. The communities have always been disproportionately impacted before COVID. It exacerbated those long-standing inequities around health, around access to health and the distribution of healthcare. If you think back, it was not only the access to healthcare, but it was the logistics around getting vaccination and testing to the underserved communities, which we were last to get those tests and get those vaccinations. It overlooked prevention and primary care, basically because the health system in the US was not nimble enough, not expansive enough, not flexible enough to continue to take care of the preventative and primary care of communities while we took care of COVID. We shifted to acute care system. Well, who falls behind when that happens? We're seeing now lack of follow-up that our communities has had, which when it comes to cancer, diabetes, and hypertension and those other chronic illnesses, basically they fester, for lack of a better word, and now we have worse outcomes. We're starting to measure worse outcomes because of the lack of attention we paid to that. So some of the things that we can benefit from is the fact that it highlighted the need for cultural and linguistic sensitivity. Some of the things that Mr. Mylan talked about, the needs of the LGBTQ community, understanding that it's a difference in how you approach this community, the culture within the community. And that goes across the racial and ethnic groups, immigrant groups, those who have been traditionally left out. We have to overcome these cultural barriers in order to communicate, see what the needs of the communities are, but also any education around a new illness like COVID. It has to be in the language of the community, but also the benefits of treatments. These communities are not uneducated broadly. They are educated folks and people who understand this community. It's the way we communicate. And we always go back to when this COVID thing started, people always look at the community like they didn't understand when you have the the healthcare leadership and the political leadership at in the highest offices giving mixed messages. So if you follow the best practices of science, you're confused. So it's not that the community is not capable of understanding. It's the fact that the messages that we gave in the US, and all you have to do is look at the numbers, is we didn't educate the community properly. We didn't give the truthful message to the community properly. But also it did show the importance of digital health and being able to using virtual technologies to reach and to treat communities. So I want to talk about a few of the things that we looked at that go along with some of the things you heard, but these are studies that we've done at the under the National COVID-19 Resiliency Network, but at the NCPC in conjunction with Moore School of Medicine and others, as Dr. Warren and others. But this talks about the variation in reporting of race. One thing we saw in Georgia was that race and ethnicity was not even reported. Now we know the importance of not only identify who was getting COVID, because then you relate that to zip codes and who needs to be treated. But the other thing is we know that statistics and data is used as far as when we finance and we provide resources to community. So a lot of states, and you see Georgia is in yellow, Alabama is in red when it comes to this. But the darker the state, according to our study, the state did not do as well as collecting this data. Now I can speak to Georgia, and we work with the Georgia Public Health Department, but we had the hardest time in the information that they were reporting about cases and deaths just lagged. And again, the demographic information that was reported was poor at best. We also looked at the Black populations in primary care shortage areas. And when we looked at the counties in Georgia, we found that just being Black, those counties that had higher incidence of Blacks basically had a higher incidence of COVID cases rates, even after adjusting for socioecologic and health system factors. That means just having more Blacks accounted for higher COVID rates. And we found the same thing as it went across the United States. And also counties designated as primary care health professional shortage areas had higher rates. And we, people of color, are usually within those areas. And it highlighted that importance of recruiting primary care providers to more rural communities, which we know has always been difficult. And this one is around Metro Atlanta area, where we basically compared two different neighborhood types. Neighborhood type 1 had a higher proportion of Hispanic population with no high school diploma, uninsured, crowded households, youngest household members associated with higher COVID-19 case rates. Neighborhood 2 was more southern metro Atlanta, higher proportion of non-Hispanic Blacks with low income, higher unemployment. And within these communities, we found again that those who, the Black non-Hispanic populations in lower income neighborhoods basically had higher COVID rates. And of course, we know with vaccinations, the same thing as far as like the distribution, but the lessons learned when it came to vaccination uptake among Medicaid recipients, which showed that Hispanic and Asia Pacific Island Medicaid enrollees in most states had higher vaccination rates than whites, but African Americans and American Indian Medicaid enrollees had lower vaccination rates. So in summation, I think earlier on in the talk, Dr. Hodge said the thing about what's next. And I'll talk about what's next after this slide. But this basically, if you see the darker colors, which is the kind of orange, the green, of course, is states that had high stay-at-home orders and high face mask policy orders. When you look at our states, like you look at the state of Georgia, which is in yellow, Georgia had a high stay-at-home order, initially like stay at home, basically, not these large public gatherings, but we had a low face mask policy rate. So basically no policy from the governor. The governor refused to say that there were face mask policy. Now in Alabama, we had Alabama as having a high stay-at-home order rate and also a high face mask policy rate. In orange, you see those states that had low stay-at-home orders and high face mask, and also low face mask policy rate, states like Florida. But basically what this showed were those states that had the high rates of orders and face mask policy did better when it came to COVID case rates and death versus those states that had low stay-at-home orders and face mask policy. Now it varied, but overall that's the message we got from the study. So what's next when it comes to looking at the COVID, the infection rates and the death rates and the studies that we were able to look at? One thing that we published was the disaster preparedness and equitable care during pandemics. What it talks about within this article in the journal National Medical Association is basically that when you look at the past epidemics, the flu pandemics, and the first flu pandemics that we hear about, the great one in 1918, so to speak, where we were only capturing data on Black and white, basically African Americans and whites. Well, the Black population, you think back to slavery and some of the things, Dr. Mylan talked about that map, where you always look at the Southeast and the southern parts. Those are also the slave states. And we've had one study where we looked at the slave states and looking at the higher COVID rates in those states that previously had high slave populations. So we go from the point where slavery, where we had no care and basically high abuse, we go to the year of the Tuskegee experiment, where we were still suffering abuse, little care in the system, but no equitable care, where we go to the day where we can say we have better care. But when we look back at the past flu pandemics, African Americans in 1918, just poor care. So high diabetes, high hypertension, high infectious disease rates, where then comes the flu pandemic, and then inequitable care and treatment during the flu pandemic, some of the same things we've seen now. Then after the flu pandemic, the disparity rate just widened. That's coming to vaccinations, the lag in vaccinations for underserved communities, but also coming in testing for flu. And we've had about 5 flu pandemics and the same thing has happened, and we're seeing it happen again. So what the argument is for this, what the discussion that's brought forth is that we need to have disaster preparedness planning that is fitted for communities, almost like those frameworks we're talking about. There are different needs in different communities. We also go back and we talk about Hurricane Katrina. When you looked outside of the dome, who was there? Well, the Asian community has jumped in trucks and they're left and they're gone to Houston more so than the African community that went to the dome. There were different access to transportation, but also different modes of, should we stay, should we go? But each community looked at it different and had different resources. We don't need to wait till a pandemic or a disaster before we start to mobilize for these communities. It's proven that these underserved communities, disproportionately impacted communities, are going to suffer the worst. We need to plan ahead of that. and funding needs to be put from the federal government and all these other resources to help with this planning. So let me move to the technology. We've done some studies to show that EHR adoption among under-resourced providers who took care of high Medicaid and high Medicare population, basically adopted electronic health record. It also with telemedicine, the uptake for telemedicine for Medicaid recipients across the Southeast was lower at the time of the study to the right that we did. These two studies, one on EHR, one on telemedicine, basically the uptake around mental health and telemedicine was higher. But when it came to telemedicine for other things, for other illnesses or other classes of illnesses, the uptake is low compared to those who are insured. And we know it's paid, it may be paid for if you have the best insurance, but if you have Medicaid, according to the state would not pay for the telemedicine visits. But we know if these tools are put into the hands of clinicians, under-resourced clinicians usually, who serve the underserved communities, that they can be a great aid. So what happened was we did a digital health tool study with funding from the United Health Foundation. And what we did is we basically measured things, right? We looked at data. We did clinical surveys and focus groups with clinicians. We looked at state-by-state policy analysis and environmental scans when it came across the states. And then we looked at secondary data analysis, looking at the health of the population, you know. And basically, our goal is to kind of collect the data and at the end have some kind of briefs and publications. But this is some of the things we found. When we questioned the providers, we end up having almost 1,000, I think we had, almost 1,000 providers in that were questioned. And about 65% of those utilize telemedicine, 65% electronic health record. But when you go down the list, you see as far as wearable devices, and these were providers who served high Medicaid and Medicare population. So we call them the under-resourced pool of providers. But as you see, when it comes to wearable devices and using remote monitoring and home monitoring, this population was pretty low. Actually, the numbers for electronic health records were lower. When you look at most across the country, it's usually a 90% adoption of electronic health record. So these providers were more rural and again, deal with underserved population in the urban community. But the interesting thing was around COVID, say, have you used digital health tools because of COVID-19? 90% says yes. And the other question was, if you are providing telehealth services during COVID-19 pandemic, was this your first use of telehealth in the practice? And 54% of these providers said, yes, this was the first time they've ever used telehealth. Again, we don't have the number here for those providers who don't serve these communities, but these numbers are impressive when it comes to access to innovative technology and digital health. These are some of the comments that we had. It's very frustrating not to be able to access records within my own system. So there still lies, it's not just the fact that you have an electronic health record, but as you talk to clinicians, just the difficulty and the level of functionality that you get with that electronic health record has still been a challenge, for especially for providers who don't have the resource to upgrade these systems. These systems do not come out the box like your iPhone. They have to be upgraded, and it costs money to upgrade, almost like you have to add all these apps just to get the necessary functionality that you need. The second thing is, the other big issue is really that the digital divide in those that have the availability and capability to utilize different networks. Now, these are comments from providers. So they saw that their own, they they could be on the same electronic health record as somebody 2 doors down as the hospital, but they still could not access those records, even being on the same electronic health record system. And the other comment is about there's still a digital divide, the have and the have-nots when it comes to accessing this information. And these are just 2 comments that were from some of the providers. So the takeaway is that adoption, good thing, adoption has increased comparatively to years ago. Primary care clinicians are generally satisfied. But we heard over and over from frontline decisions, clinicians, they would want to be engaged in the development of these digital health tools so it could benefit their practices and their communities. When you look at health equity implications, the COVID-19 policy changes improve access to telehealth, as we talked about, but really there's not any evidence that it really decreased disparity reduction. As we know, there was a big issue about the homework gap, right? It took a while for the disproportionately impacted, we think about the inner city African-American, the rural African-American community. It took a while before these people didn't have communities at home when they wanted to start teaching at home. There was a lag. I know in Atlanta, we finally got computers out, made them available free of charge, but initially it wasn't. And then once you get the computer, do you have connectivity at home? So the homework gap is similar to the telehealth gap. If you can't do your homework from home, you can't receive telehealth from home if you don't have Wi-Fi available or computer available or the connectivity available or a smartphone that can be available. And then the second thing is the digital divide continues among consumers and clinicians in rural and underserved communities. That means the digital health tools that are available. That's including the diagnostic tools that are in hospitals, that are in practices. It's the have and the have-nots between the larger health systems and the smaller primary care practices, solo practices that are slowly closing. So I want to leave this part with this, and then I'll go to the end. We'll talk about INSERN, and then I'll close out. But the healthcare has changed. We've heard about IBM Watson, which I heard IBM, it was up for sale. You don't hear much about it now because I think they're selling it. The technology is being used in multiple areas. They don't have to harp on that name as much, but the job has been done as far as like selling the technology, the development of AI tools. I just want you to think about it. IBM, they were, you think back, they were a computer company that jumped in healthcare. Healthcare has become attractive, and you think about the way they think about health. And I'm not knocking that. These tools are great, but the business approach to healthcare has really changed the healthcare model. And the second thing, if you can see it in the middle, it says Amazon, Berkshire Hathaway, and JP Morgan team up to try to disrupt healthcare. We know Walmart is putting healthcare. And well, once they put it in, I'm not saying they're not trying to improve the health of the community or the health of the employees, but there is a business model behind that drives that. So I'm gonna just leave that open for you to think about, but the state of healthcare has changed. And even when it comes to electronic health records, and we know Epic is a big one, but you can imagine the monopoly. It used to be multiple EHR systems. Now is pretty much being monopolized by these big players in the market. So that's a conversation beyond the scope of this one, but that brings different threats into healthcare and the way it's changed. Some positive things, but also we can argue some negative impacts. So let me end by just kind of just give you an overview, and this is the work that we were doing with Dr. Warren and team at Tuskegee around the National COVID-19 Resiliency Network. in which we received $40 million, Office of Minority Health, over a 3-year period to really try to develop, engage disproportionately impacted communities, create active information dissemination network, basically overcome those barriers, be able to communicate to communities, look at those ethical issues, but also look at the barriers that prevent them from going into care around COVID-19. So we're to look at that, but be able to develop messaging that would link them to healthcare and social services, and monitor and evaluate the effectiveness of this model, but also bring awareness and participation through dissemination of scientific methods. There are multiple partners that we've worked with this. We've worked with we have our contracted partners, we have our strategic partners like Tuskegee University, but we also have some partners that, have no obligation to the mission, but they engage. We have these events where we have national meetings. Our last community exchange meeting had over 100 organizations, multilingual, multicultural, engaged in conversation, sharing best practices. And we highlight those practices across the organization: Alaska Native, Pacific Island, American Indian, African American. Over 400 partners have engaged since we've been here. And we've developed multilingual, multicultural communications to try to overcome those barriers that we talk about. One of the things that have been successful is, and this highlights our round 2 of micro grants, we're now in round 3, but actually to give micro grants to community-based organizations to do the work that they're already doing within communities. This particular round of grants basically impacted over 3,000 community members. And the community-based organizations, which were part of this, some of the awardees conducted research. Six of them were in different regions, 6 different regions, HHS regions of the country. 10 awardees were actually administered vaccines to the community and other information, but it attracts diverse community-based organizations which have different models and different methodologies of outreach, which helps the INSERN to share best practices. So there's a technology, you can download the website. Just go to your Google or your App Store and just put in NCRN, and it's a free app. Download the app and you'll see the resources. We also have a call center, and you can access it through the website. And there's a language selector and symptom check on the website, but you can also get location-based resources, which includes where can I get a vaccination, where can I get tested, mental health services. And we're all going to those social determinants where you can also, if food insecurity, if you're looking for a job. So we're trying to make it more robust where it addresses those social determinants across community. And then also look at my area. It's updated with data from across the country. And according to your zip code, you can look and see what the COVID outbreak and risk will be in your area during the time. So this, as you see, can be translated not only from COVID, but during post-COVID time when we get there, where it's not such infectious. We could do the same thing for diabetes, for hypertension, support the gathering of these partners to have a continuous ongoing dialogue and sharing of best practices, looking at this data, where we get to the point where we're ready for the next disaster or the next pandemic. We've utilized our own resources to kind of build a network. So the aggregation of data is what we're also trying to do to inform, not just to collect data or to make any money off of data, but to inform, to develop a data landscape that would be valuable to minority institutions, to community-based organizations, where we can go in and we can look at this information and actually better inform and develop programs for our communities. So this is just the back end. And please contact me if you're interested in any of this, but this is the back end where you can go into the database portal and you can look at, those areas, in my zip code, you can overlay diabetes and COVID, hypertension, diabetes and COVID, and just see the prevalence of it within communities. You can do low level or high level scientific studies. So anyway, just wanted to give you that overview. Thank you so much. And definitely, again, thank you, Dr. Warren, for inviting me, and look forward to any questions.
Thank you so much, Dr. Mack, for your informative presentation. We have 2 questions. So the first question says, would the system have worked better in giving access to healthcare in the local churches, holding clinic days at the churches or more comfortable settings and environments to close the gap?
Well, to echo Dr. Warren, some churches did that. There were some churches who really participated. We actually, in this model, we have partners who work primarily through churches, partners who are churches. So yes, probably if we've been able to have a broader approach across more churches, I think it would have been better. But there were some communities and some church leaders who participated and really pushed it in the church. And then, of course, as we know, other churches just kind of closed their doors. But yes, if it had been broader, that would have been a good approach.
And the second question is actually a request. They're asking if you would please put the slide for the website back up.
Okay, and we could put it in the chat. Let me just, so I'll be correct. Let me just Google it and post it in there. Make sure you can go to it. I'll post it in the chat. And as far as like the app, you can just go to the App Store and put in NCRN. And that's all you need to do. But I'll put that in the chat, the website. I'm getting it now. Let's see. I think all I'm pulling up is, I'll put it here. I think you might have to put it in there, Dr. Hodge.
Okay. All right, we see it.
I don't know if mine is just going to the host and the panelists, but if we can just.
Oh, I see it. Okay, all right, thank you. I'll take care of it. And before we introduce Dr. Warren, I just thought the whole presentation was absolutely brilliant, not just because of what was done to look at indicators, but and algorithms and such, but the long-standing beauty of this is what can be done with it in the future. I thought when coronavirus first hit and Albany was hit so hard and so many people were dying in Albany, what's the name of that anchor from CNN, who the Vanderbilt, Anderson Cooper. Anderson Cooper went to Albany and he said, what's happening in Albany is criminal. This should not, why is there such a high prevalence of deaths for African Americans when this is a virus. I mean, virus doesn't have a name or agenda unless you create an ecosystem for it to thrive. And so it hit me, the term criminal, which is a term that Mr. Mylan used earlier, right? The criminalization of AIDS. I thought about it. What happened in Albany is not what happened was criminal, is what took place before the pandemic was criminal. That is the inability for Black and brown people to have the necessary kind of public health and healthcare that they need to thrive. That was the criminality, that because of comorbidities, they necessarily were the first and the hardest hit. So if there isn't a system, as Mr. Mylan was talking about earlier, that took advantage of and took seriously the healthcare issues that are on the communities of poverty and communities of Black and brown people, then we have a major situation. So what?
Yeah, let me just say something to that, if I could, quickly. You're so correct. What acute diseases do? They speed up everything, right? If diabetes was an acute disease, we'll see this every day. So what comes along is acute, like a disaster, and it speeds up everything. And what it does, it brings to bear the same things that we've been facing before. The inequities, they float to the top quicker. So whereas it takes years, it kind of can be subtle, insidious more so with diabetes or hypertension. When COVID comes, it's fastly approaching, and you see the white counterparts die besides us, but we're dying twice as much. So yes, great point. But what it always does is, just like, again, Hurricane Katrina, what it did was, it's right there in your face. It's not insidious anymore, because it's, we're showing where we usually put this population. This is where they fit in. This is the way we treat them. This is the order in which they receive healthcare. This is their assets. Well, when you're diabetes, you're not running to the shop every day. But if you get acute illness like this, you got to run now. And then there's no door open for you to go through. So, yeah.
Interestingly, Katrina was this exact illustration I was going to use, because they knew the levees were weaker than the 7th and the 9th Ward, right? They knew it. Sooner or later, an ex-hurricane or ex-bad weather just happened to be named Katrina is going to come and devastate those levees, and they're going to break. Right. And who's going to get hit? Those populations just mentioned in this community, because they already had the undergirding susceptibilities. So what your project is doing with what the project is doing, the National Coronavirus Resilience Network, is the genius of it for me is that it brings to the conversation now, because another pandemic is coming, right? It's coming. We don't know when, but there's another one's coming, and maybe pretty soon. I saw with monkeypox, right? It was on the door. Right after this one, you have this other one ready to come. So another pandemic is coming. But what this does, what I can foresee with this project, is that it highlights and let us know where those particular communities are with diabetes. Forget that. With all of the 8 or 9 excess death categories that Black and brown people lead in, all those categories are covered by Black and brown people, including Native Americans, right? So all those categories are covered. So now once you can highlight and identify those areas, you're 100% correct, in my opinion, that now you could create systems and improve upon existing systems of healthcare to make sure that this malstructure doesn't continue, so that when the next system comes, or next pandemic comes, we'll be prepared. We have some more questions in the queue before we move to Dr. Warren.
Yes, Dr. Hodge.
Okay.
I would like to ask Dr. Mack, in terms of his grant, in terms of the project and the grant, you said $40 million that
yes,
you all got for that, yeah. What percent of that has been used for for helping us morally and ethically to understand what's happening to us in the Black community.
Right. Well, let me say
let me give another make another attachment to that. Was there any attempt to work out anything with ITC, which trains a big portion of this country's clergy persons,
right,
to bring them in, or at least classes or projects or whatever, to better understand the relationship between science and medicine? I'm sorry, science and religion, medicine and religion. It seems to me, and having taught there for years, that one of the problems in the Black community is, and when I first came here, I asked to, I think I taught a course with a gentleman. He wasn't trained to do this. He was really a Episcopal priest, but he wasn't trained in ethics. But the school used him anyway, so that was, you know, that was their choice. But what I see, one of the problems that I see is that we are not helping our people to understand the relationship, the technical relationship between religious faith practices and scientific query or scientific practice. And I don't see how, I mean, I've asked repeatedly, how can the School of Medicine sit there and with this other school over here, and we not, the professionally trained people, not really explore that issue? Because if we don't explore it, we are missing a great opportunity to try to help our people. Because we are getting further away from, in the Black community, further away from the importance of scientific medicine than we were when I was a little boy. Now, and I'm 80 years old, and I hear people talking foolishness about healing and health now that I didn't hear at the level that I'm hearing it now. And that's frightening to me, because when a pandemic does come, it knocks the hell out of us. You know, okay, I don't go to the doctor. I know I got diabetes. I know I got this. I know, but I'm going to take it to Jesus. And if I don't take it to Jesus, I'm just going to try something my grandmother was doing, you know, etc. So that, anyway, let me respectfully let you respond to it.
Yeah, thank you, Dr. Earl. And to your point, I think some of the things, you know, social media, people now get the information from all sorts of places, not just their provider anymore, who doesn't know everything, but is you know, we know that. As I stated with COVID, part of the issue was we had a president and we had physicians who were in leadership position who was spewing some of the misinformation. So it comes from everywhere. But to your point, we didn't address that. We did have specific objectives, but we did, and we kind of marched it out. We did engage across, you know, 5 predominantly affected populations. African American population were the largest population engaged. And as far as the funding was, in that order, we engaged across the populations equitably, but equitably according to their size. And we have a number of organizations, including Tuskegee, 100 Black Men, and some others, organizations that are community-based organizations that are religious-based, but also we have one organization that primarily works with churches to try to distribute the message, but also gather information as broad as we could. We realized we couldn't hit everything, and $40 million over 3 years, as you know, across the nation is not a whole lot. But I think you bring up an important point. I do think within the schools, we are developing a lot of pipeline programs for the youth as far as like trying to get them understanding, but other outreach programs to different communities, including maternity-based programs, aimed at fathers and others. But I think bottom line is, to your point, there is a need for better understanding and those who are training in the ministry and other places.
Okay, yes, it's very needed. And of course, the beauty of ITC in terms of the Morehouse School of Medicine is it serves, because it's entered in, you got all these different leaders being trained from different denominations. It helps us to be better in touch with, or it helps us to be in touch with the communities of these denominations, and also, if I can, if my language, if my faith language is so powerful that it helps, it's really going to reward me financially to preach stuff I don't believe. And the, sorry?
No, continue, Dr. Earl, continue.
Yeah, and if it helps me to preach stuff I don't believe, and it goes against the grain of the health interests of my people, that becomes a very frightening scenario for me. That, I think that professors, there are some professors who need to be more in conversation with some of your professors in terms of how we can better strengthen what we are doing for our people than has been in the past.
Yeah.
Thank you for your presentation.
Thank you, sir.
We had a few more questions come in.
Wait, one question. Sorry. One moment, please. Dr. Mack, I was told that you have to leave, or can you take a couple more questions?
I can take a couple more.
Okay, all right. Thank you, sir. Appreciate it. Continue, Mr. Miller.
So Loretta Hicks sent in a question. She asked, how does MSM influence the increased number of next generation of healthcare providers, researcher, and community workers to impact healthcare disparities? And she also asked, how is TU assisting this effort?
What is assisting in the effort to me?
How does MSM influence the increased number of generation of healthcare providers, researchers, and community workers to impact healthcare disparities?
Okay. Yeah. As I mentioned in response to Dr. Earl, we do have a number of pipeline programs, school adoptions, where we work from, lower grade school levels into high school, but also summer programs for those in college who are interested in going into medical school. We do a great deal of mentoring within the community. And then also we have, just like with this program, which we go seek competitive awards, we have experts in child care and other areas, maternal care, where we also, whether it's through federal funding or institutional funding, reach out to communities to educate and to also recruit about the health professions. We've expanded our curriculum beyond MDs, of course. We have a physician assistant program. We have a master degree program and other doctorate programs in other scientific areas, not just MDs, medical doctors. So yeah, we do a number of things through research, evaluation assessments of communities and how to best get our people in the pipeline to become researchers and to become physicians, but we also do outreach, especially in the metro Atlanta area when it comes to working in schools and other institutions to draw people in. And generally, we educate, we were awarded for our mission, which means we educated, we accept and we educate more folks from underserved communities, specifically African Americans, and we train those. We won an award for doing that more than any other medical school in the country a few years ago. But also, thank you, Dr. I see you clapping. But also, I think over 50% of our graduates remain in Georgia, and even more than that in the Southeast, and go into primary care. So.
Ms. Hicks also had a follow-up question. She asked, how is Tuskegee assisting this effort?
Well, he's up next, so I'm gonna let him tell you more. Nobody can say it better than Dr. Warren. So I'm not gonna attempt to try to say, but I will say this is one thing that he always said, that when this happened, nobody called. Everybody was talking about Tuskegee. I'm gonna steal your line, Dr. Warren. Everybody was talking about Tuskegee, but nobody called him. Well, we called, and I called Dr. Warren because all this stuff and this OMH wanted to do, we needed, I thought, ethical oversight. And yes, the main thing, we're talking about Tuskegee and the Tuskegee, everybody knows that. They might not know what's behind it, but they know that. And how we were treated. But again, as Dr. Warren said, no one called Tuskegee, but it was all off the tip of the tongue. So we came to Dr. Warren and the team because we knew that's where we best could get the guidance and the scientific guidance to make sure that we were implementing this properly outside of just having them on board as an institution, as a partner in this endeavor. So that's, again, he can briefly tell you specifics of it, what we're doing, but that's basically it. Our advisor for this program, how we assess and how we implement equitably and make sure what's happened in the past did not happen again.
I'll talk about it later on, but Dr. Mack is saying exactly right. He called and we talked and we continue to talk. He's the only call I got, and we appreciate him for that.
Thank you, sir.
All right, the final question, the final comment and question, Jamelia.
Why didn't we immediately work to protect people in those communities? Is a question from Lachlan Farrow.
That's the question. We try, the why. I started talking. I sound like I hear Dr. Warren in my ear, but the why, that's a big question. What, why inequities? What's behind inequities in community? It's a system, and it's people behind the system, but it's a system that's already there. But all we can do, we continue to, how can we, maybe figure out why, but how can we find solutions? I think that's where we kind of put our focus. We know there's racism, we know there's, inequities and disparities, and we know there's systematic structural things that are in place. So we know that. So that's part of the why. But what we're trying to do is, not only just concentrate on that, but concentrate on the change going forward. So, but that's a big question. Yeah, it's a big question. It takes all of us to answer, But thank you so much for having me today, and thank the audience. I do have to go, but Dr. Hodge, thank you. Dr. Warren,
Thank you, sir.
and Dr. Earl, you keeping us on point. We appreciate you, sir.
Okay, thank you so much.
All right, thank you.
Thank you so much. Ms. Harris, can you please introduce Dr. Warren? He's up next. He has about 15 minutes. So so you don't have to read his whole dossier, just the first part.
Okay. Dr. Rueben C. Warren is currently the director of the National Center for Bioethics and Research in Healthcare and professor of bioethics at Tuskegee University in Tuskegee, Alabama. He is also former director of the Institute for Faith Health Leadership and adjunct professor of public health, medicine, and ethics at the Interdenominational Theologic Center in Atlanta, Georgia. From 1988 to 1997, Dr. Warren served as Associate Director for Minority Health at the Centers for Disease Control and Prevention. From 1997 to 2004, he was Associate Director for Urban Affairs at the Agency for Toxic Substances and Disease Registry. From 2005 to 2007, Dr. Warren served part-time as the Director of Infrastructure Development for the National Center on Minority Health and Health Disparities at the National Institutes of Health in Bethesda, Maryland. From 2004 to 2009, he was on leave from the National Center for Environmental Health in Atlanta, where he served as Associate Director for Environmental Justice. As Associate Director at the CDC and the ATSDR, Dr. Warren had led agency responsibility for environmental justice and minority health.
Dr. Warren?
Share screen and what? Good afternoon. Yeah. One second. I'm going to be brief because what Dr. Mack actually talked about was ethics. You heard his comments, you heard his orientation, you heard it was absolutely brilliant. What's important, I think, is I hope you heard about his background. He started at a community health center, a federally funded community health center, which serves those who don't have the resources to get their care. And that brought him to the Morehouse School of Medicine. So he brought the lived experience to the academy. And you also heard that Morehouse was the leading medical school in the country with a social agenda, the leading medical school in the United States. So it was the perfect place. Last and most importantly, $40 million sounds like a lot of money. And in fact, it is. And it scares a lot of folk from even applying. Dr. Mack had the courage and the expertise to apply, and they got it. So I'm very proud to work with him. The African-American Petri dish. In 2020, we published an article in the Journal of Healthcare for the Poor and Underserved. And it really reflected back on something that happened in 1974. Victor Fuchs, a health economist and professor at Stanford University School of Medicine, wrote about a book, and he entitled "Who Shall Live?" And it talked about the disparity in the health delivery system and how it inequitably focuses on certain populations. And we know what those populations are and continue to be. What was acted as if it was a surprise and COVID-19 hit this country, coronavirus panic started, as if we were surprised about who was suffering, who was infected, who didn't get hospital care, and who prematurely died. Victor Fuchs talked about it in 1974, and I won't belabor it. I can go back to 1619 and talk about the same dilemma. And here's some language I want you to think about as the coronavirus pandemic emerged. They talked about hesitancy and denial as if they were the same thing. Hesitancy is a reluctance or refusal to, despite availability. Denial is refusal of something requested or desired. Their words are very different. They talked about hesitancy as if it was denial. I think recent data will show that, particularly in the Black community, the participation, the vaccination rates have increased phenomenally. They also talked about reluctance versus refusal, and there's a difference. Not wanting to take the same action or unwillingness is reluctance. Refusal, the fact that of firmly denying that you will not do something, regardless of what. So I would suggest when the coronavirus pandemic started, we were at a pause. We temporarily stopped action until we found out more about what was actually going on. And I was about a part of that pause. And Dr. Mack talked about a relationship between Tuskegee University, the National Center for Bioethics and Research in Healthcare, and this whole notion of the coronavirus pandemic. He called me saying that he heard about people talking about Tuskegee when they talked about the coronavirus pandemic. And I told him, as he said, nobody called me. And I would suggest they didn't call Dr. Hodge either. So we paused and he said, well, what can we do together? And we talked about it, thought about it, and I proposed for him to develop a public health surveillance system. And this is what the public health surveillance system really does. It's a public health surveillance system. It's an ongoing systematic collection, analysis, and interpretation of health-related data, essential to do the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. Timely dissemination. Public health surveillance can be used to do many things. Identify patients and their contracts for treatment and interventions. Detect epidemics, health problems, and changes in the health behavior. Estimate the magnitude and scope of health problems. Measure trends and characteristics of disease. Monitor changes in infection and environment. And lastly, develop hypotheses and stimulate research. So as we thought, and as I talked with several colleagues, Dr. Hodge, an epidemiologist, medical epidemiologist, Dr. Chuchu and Wachi Saunders, and an evaluator, Linda Horenstein, we talked about what can we do to make a difference instead of responding to problems, to try to prevent the problems. So we talked about developing a ethics and social justice surveillance system. And that's what I proposed to Dr. Mack. And he said, I'm not sure what that means, but go at it, go forward. So my colleagues and I developed this system that did the following. The surveillance system is aimed to provide underserved populations who have historically been subject to ethics and social justice violations an opportunity to share their experience related to the coronavirus pandemic that may place them at risk for violations. If the risks are identified, we will increase the possibility of preventing ethics and social justice violations from occurring. What we argue was that if we could identify them early on, the risk factors, then we could possibly prevent them from happening. And we knew that they were out there and going to threaten the populations that have been underserved. So we developed an active surveillance system. That is, we didn't wait for them to call us. We developed a system, we're implementing the system, and we're calling the folks to say, are there violations that you think may prevent you from engaging in all that's available to prevent coronavirus pandemic from getting to your community? And that's what the system did. And let me tell you what we really wanted to do. We wanted to really talk to the clinicians and the community-based organizations about what surveillance really was. And we wanted them to be able to report to us if there were violations that they thought was either ethical or social justice violations, and put it in the system. And then we could analyze the data, share that data with community, and try to respond proactively rather than reactively. So we talked about the system and we've been working for it. First year, we developed the system. Second year, we evaluate the system. And this year, in our third year, we are implementing the system. So we're excited about what needs to be done. We're excited about our ability to do it. And we really appreciate the engagement that we're having with Morehouse School of Medicine and other communities around the country. And in the interest of time, I won't go into the more detail about the system, but what I want to leave you with is the notion that ethics and surveillance, social justice and surveillance is new to the public health community. And so they're wrestling with it. And we wrestled with them for the last couple of months, really, and tried to help them understand that we're not trying to do research. What we're trying to do is assess and evaluate and then make recommendations to the Morehouse School of Medicine. That's what the system intended to do, and we look forward to making it happen. As I would close with this, I think this quote from one of my heroes. You know, we always talk about science and the value of science, and quite frankly, the lack of what science has done to help everybody. And we talk about the U.S. Public Health Service syphilis study at Tuskegee and what it did not do, and in fact, the harm that it did. But I want to shift that scientific, if you will, conversation to really a quote from Maya Angelou, Dr. Angelou, and she says simply that history, despite its wrenching pains, cannot be unlived, but if faced with courage, need not be lived again. And what we argued then was that the coronavirus pandemic was a repeat of history that need not be done again. And we believe that our social ethics and social justice surveillance system can prevent the kind of atrocities from happening again to the same population that have suffered in the past. Let me close by saying thank you. You see a Sankofa bird. In the interest of time, I won't go any further, but the Sankofa bird simply says that if you look back and learn from the past experiences, both good and bad, you will not have to repeat the bad, but you can manifest and explore and enhance the good. And on that note, I will close, so we'll keep you all on time. Thank you.
Okay, I was trying to end session. Thank you so much, Dr. Warren. Jamila, we do have 3 minutes. Are there any questions in the queue that we could reflect on?
There is one question. Someone would like to know, did Tuskegee and Macon County benefit from your work, Dr. Warren, in getting vaccines into arms?
We think we were part of a movement in Tuskegee and Macon County to get more people vaccinated. What we did note is that when the vaccinations became available in Tuskegee and Macon County, there was a rush of people coming, and we looked at the license plates, and they were from all over the state. And the notion that Tuskegee residents were refusing to be vaccinated is false. There was hesitation, and now we see that the vaccination rates in the Black community have enhanced tremendously. So we think we're a part of that movement, but we didn't create it, we joined it.
Dr. Warren, can you share something about the what you call those the small groups sessions that you led on this topic?
Oh yeah, we when the people would come to Tuskegee and ask questions about quote unquote vaccinations in Tuskegee, what we did, we decided to hold some focus groups with a cross section of what we call people in leadership roles, public leadership roles in Tuskegee, the mayor, the chairman of the county commission, some faith leaders, some academicians, and we had a conversation focus group and said, answer important questions. Questions like, what was the impact of Tuskegee, quote unquote, the U.S. Public Health Service syphilis study at Tuskegee on hesitancy? What are your concerns about vaccinations? And what we found was there was conversation, but it wasn't a Tuskegee conversation. It was a national conversation. We took their the responses from the focus groups and translate that into actions within the Bioethics Center. So we went out and started listening instead of talking, and we learned a lot more than we could have taught.
Very good. I think that really clarifies the answer to your question. Thank you so much, Dr. Warren.
Question.
Yes,
Question.
Dr. Warren.
Yes, Dr. Warren, thank you for your presentation. But Dr. and I think he didn't get, probably didn't intentionally not tell us, but we didn't hear. I raised a question about the allocation of his of the 40 million to ethics and the work that you all are doing. Do you have an answer of that? And I raised it because ethics is not considered a major player in the work so often that medical people do.
Yeah, I can't speak to the dollar allocation, but I do know that what Dr. Mack committed and we've agreed to is that developing this ethics and surveillance system is a way of contributing to raising the ethical issues, the social justice issues continually. So the system will not end when his funding is over. This year, we hope to actually start the system and actually collect data on a quarterly basis and analyze that data. So I don't know the financial allocation, but I do know that we were funded to develop the system and implement it.
Was there, in terms of what you have planned at the center, do you have a guesstimated budget or what it will take to do what you're proposing?
No, what the dollars we got implement the system, but for it to be ongoing, we hope that the data that we collect will encourage the Department of Health and Human Service to keep the system going on. So we were funded enough to have a couple of consultants and for an advisory committee to really talk about how we implement the system. But in terms of the total $40 million, we were very small part of that. And in fact, ethics was not considered until Dr. Mack and I had the conversation.
Thank you.
All right. Thank you very much.